Pronto? Certo. Allora, benvenute e benvenuti, sono Nicola Di Lernia, è un piacere.
Welcome, good afternoon. I'm Nicola Di Lernia, and I have the pleasure to moderate this roundtable with key representatives of the eyewear world. Rino Agostiniani, president of the Italian Society of Pediatrics. Well, we all know pediatricians. And Marco Montes, he's a delegate for the Italian Association of Orthotists. And then, of course, I'd like to greet the people I know, the president of Federottica. I'm joking. Fragoli, Paolo Nucci, and Romolo Protti, so the president of Federottica, the president of the Association of Pediatric Ophthalmology, and the vice president of IMO. Am I right? Okay, no mistakes. So today we are going to review some of the steps of the ideal process for young presbyotic patients. Well, young presbyotic patients are the ones I prefer. Oh, myopic. Oh, I'm sorry. I made a mistake. Well, it's my 6th roundtable, and I have to tell you the truth. I'm a bit confused, but by 6 p.m. everything is going to be all right. So we're going to talk about young myopic patients and up to the young presbyopic patients, because that's the path. So from myopia to presbyopia. There's a movie by Matt Dillon, if I'm not wrong. No, it's not Matt Dillon, but it's not important. Well, a movie with a great actor who was born old and dies young. So, Professor Nucci, could you please introduce the starting point of this process? Because we've always talked about myopic progression, but we have to do with young myopic patients who, however, are going to grow up and they need to be supported. But let's start from the beginning. All right. So I've always been myopic. At 5 years old, I needed spectacles, and as my father was very attentive, he was a doctor, he brought me to the eye doctor, and he put eye drops into my eyes, and I suffered a lot. And then I was diagnosed with myopia, but back then they told me that no correction was needed, and so at my age, and so I continued to live my life as a young myopic child with a lot of difficulties. When I went to the cinema with my friends, I could hardly see, and so I suffered a lot. And so I will talk about myopia as a sufferer. That's why you became an eye surgeon. I think I became an eye surgeon because of money. There was an economic reason behind that. I was told that eye doctors, eye surgeons earn a lot of money. That's why. So if I have to go through the myopic process, I'd like to resort to my experience. In 2012, I was coming back from a congress by the American Academy, and there was a speech on myopia, and the first articles on medical treatments were published. And back then, at that conference, during a roundtable, I saw a room full of eye doctors, 800 people, so there was a lot of interest and maybe also some novelties. When I went back to Italy, I started dealing with myopic literature, and it was really fascinating. There were a lot of new things, not only drugs, but optometricians were also engaged trying to understand why people developed myopia and what could be done against it. And so back then we started to see the first contact lenses, however with not great success. and the first suggestions about the so-called bifocal lenses, because back then people believed accommodation was key, and there was a world that I could not understand. And then works by Medina were published about the visual biofeedback. The eye grows based on the stimulation by images that reach the peripheral areas in a blurred way. So in 2013, 2014, literature was really very advanced. The first lenses with peripheral focus were presented to me in 2020, although I knew in 2015 that Copper Vision had already started developing such lenses. But what was the mistake of Copper Vision? They met me and they proposed, they recommended that I used these lenses, but I simply said, so it was not important I asked a sentence to be cancelled, that is, that cyclopedia was not necessary for children. I simply said, please don't say that you can prescribe spectacles with spectacles to children without a cyclopedia, because children simulate a lot, and so drops were important. And so there was no relationship between me and the company, but then with Oya and Silvano Rarcher, we established a very good relationship. They were the first to offer bifocal lenses with peripheral focus, and we as eye doctors could be great drivers for the development of that market. And from that period onwards, a lot of interest developed. Companies thrived with EssilorLuxottica, then Zeiss. American Seleco is also entering this segment now. So you see, there's a virtuous cycle. The doctor, the eye doctor, approaches the industry, and now this virtuous cycle was completed. And this is the positive message. Collaboration is key now more than ever. There must be a very close collaboration between doctors and the industry. But scientific evidence helped you a lot. In the ophthalmic world, there was not such an evidence. There was literature, but was somehow neglected. Optometrist and Vision Science, this magazine, for example, were neglected by doctors. But then when you start reading articles in these magazines, you realize that there's a lot of culture. There's plenty of culture that you tend to neglect. Well, Fragoli will be happy to hear that. Nucci said encyclopedia is usually linked to ophthalmology rather than optometry, but this is not the case. Okay. I don't know if I was able to reconstruct the whole process. I'm curious to know about the relationship with pediatricians, as we have the president of the Italian Association of Pediatrics. How does it work? Let me introduce Reno Agostiniani. He is the president of the most important Italian society. I think there are 10,000, 11,000 pediatricians who are members of this society, and we have to look at these heroes with the utmost respect. Italy is the only country where you have the privilege of being born and being referred to a doctor, and that's really important. You're born and you are referred to a doctor. Well, of course, this type of medicine is less profitable than eye surgery, but and little is known about pediatrics. Yes, but you have to know that all children are referred to pediatricians. That's why preventive treatments by pediatricians are extremely important. And well, I've always said that these gatekeepers are very important to us as well, and nobody believed me. And together with Fabiano, well, we decided to invite a pediatrician today at this panel because this role has to be highlighted. And that's important because talking about myopic progression, we missed the the pediatricians in the past. Well, pediatricians, of course, cannot have the skills and the abilities that Paolo referred to, but what he says is absolutely right. A pediatrician is the doctor who is able to refer children and their families to the right practitioners, especially when decisions have to be made, not only in terms of healthcare during the pediatric age, but also for the years ahead. We know nowadays that most non-transmissible diseases in adults start in the pediatric age. So if you understand how important it is to invest in the first years of life is extremely important rather than repairing broken adults at a later stage. Let's try and allow people to grow healthy, but you shouldn't start when people are 50, but when they are children. So I think pediatricians should have an important role. They should be able to identify problems when they start to emerge, as it is the case for myopia, for example. There are signs that can be identified by pediatricians, and pediatricians can then provide advice to the parents and refer them to the right practitioners. And besides that, lifestyle is important as well. We started a campaign on lifestyle, because based on lifestyle you can properly manage future problems and future conditions. Well, I like very much the idea of the broken adult, but from the viewpoint of the optometrist, so how can you consider, how would you judge the situation of children nowadays after the COVID pandemic? I will try and be very brief on that. So there are less and less children, and children become weaker and weaker. And I don't mean physically weaker, but weaker from the viewpoint of the relationship, the psychological dimension, the relationship with their peers and with adults. And the pandemic was a very difficult period that had a huge impact. A lot of problems and conditions we are confronted with when we have to do with children and their families are linked to this loss of relationships, excessive use of means of communication like social media that are linked to myopia, but that have a much stronger impact on the social relationships. President Fragoli, so we've gone through the pediatric world, children growing up, and then children end up in an eye clinic. What do we find there? Well, we are all confronted with a problem that has become much more severe. So it used to be limited in the past, and now we realize that it is becoming increasingly important. There's a different type of awareness also thanks to the research studies, to technologies providing products, and thanks to that we can now offer our young myopic patients a management path that is potentially very interesting. Although we do not carry out scientific studies in Italy, as it is the case in the United States, and we could briefly talk about the differences between Italy and the United States, but let's put this aside. Well, it's also true that we see young myopic patients every day, and to them we offer technological solutions that are supposed to be able to slow down the progression of myopia. And as a matter of fact, and I'm not mentioning anything scientifically important, I'm just referring to the experience that I have and that many colleagues have. Well, we recognize that when our patients come back after a year, well, these products and these technologies do work. So there is something that is working properly and that should be exploited much more. But does this relationship work with eye doctors as well? Well, if the technology and scientific research show to us certain things, I think we should also stop saying to children that they have to be undercorrected and that they should wear monofocal lenses, because this is still the case today. Nucci. I've been teaching for many years, so I'm not surprised. There's still a good amount of colleagues who opt for monocorrection, which doesn't make any sense to children because it complicates their life as well. But apart from that, well, this approach doesn't make any sense. The idea of the awareness, and Romolo is the vice president of IMO, an association that is in charge of scientific training. Well, Romolo, in the last years, I think we had two roundtables at every conference dedicated to myopia, and there were a lot of participants. Yes, we have the task of training people and informing people about the new technologies available in the industry. As we said multiple times, we presented a lot of products, drugs, but we don't know then what lenses are sold. And for this reason, we are trying to collaborate with them and to provide training and education so that our children in the future can enjoy better quality of life. Well, you know, I remember when I was a child, well, you know, there were those artisans shouting on the streets to sell this and that. Well, it's somehow the same situation that we have on the market. All this shouting on the market is really disturbing. And unfortunately, this is what we are experiencing at Mido too, where, you know, this is my 15th edition of Mido, and unfortunately, we have to have these roundtables with all these noise. Well, going back to the topic, it's also important to organize meetings together with a pediatrician. Pediatricians are those who should recommend an eye checkup not only when there is a problem, but as part of the culture. Because the eye doctor is in charge of diagnosing child with any eye conditions or eye problems, and for this reason pediatricians should be collaborative vis-a-vis eye doctors, and knowing what technologies are available on the market is a must for all of us. We have to inform about medical diseases, and we have to inform about the technologies available in the optical world. And now, Montes, I'd like to tell you a story about him. Well, I was at a conference organized by Banca degli Occhi, and we were talking about myopic progression. An eye doctor said, I'd like to have a presentation by a group of orthoptists who work with me and who are following a group of young patients. And a young optometrist orthoptist gave this presentation, and I discovered that this profession is also available on the market.
Percorso.
Yes, first of all, thank you for your open-mindedness. Can you hear me better? Yes, okay, perfect. Yes, thank you for having referred to our profession. This profession has been existing in Italy since 1955. It is included in the welfare system. If we take a look at the nearsighted patient, we have to consider what Dr. Agostiniani and the previous speakers just said. A nearsighted patient has plenty of comorbidities, so he or she requires a check also from a functional viewpoint. Little children that come closer when we speak suffer from nearsightedness. They have difficulties in choosing what the environment offers them. If you get closer to a TV, it doesn't automatically mean that you are nearsightedness. So you must make a very precise diagnosis of nearsightedness. There are many different forms of binocular vision unbalances, and they tell us that something is not working. There are things that we hardly observed in the past. I have been working for over 30 years before the pandemic. In approximately 25 years of experiences, I saw only 6 or 7 cases of such a deviation after 2020. In 2020 only, almost 40. So there is a change in attitudes that have an impact on the well-being of children. The management, the assessment of young nearsighted patients requires team work. The pediatrician, the eye doctor, etc., to see where are exactly the problems with this young patient. Yes, Miss Dr. Afragoli. When a young nearsighted patient gets to an optical center, he or she is never alone. What can you say based on your experience about the relationship to the kid and to the parents? Where are the difficulties? Well, we're talking about a pediatric age. The concept of pediatric age is not so well defined. It is clear that a 5-year-old patient who suffers from nearsightedness differs from a patient who is 16. So there are political reasons behind this definition. Anyway, we're talking about patients who have a completely different structure. So when you have a patient who is 5 years old and has a slight hypermetropy, and probably this hypermetropy will be reduced over the years, and this patient won't need glasses any longer. Then if a 5-year-old patient is nearsighted, then the patient and his or her parents must be aware that this disease won't go away, but probably will get worse over time. So And this also in terms of eye diseases. So what is important is to have a special approach towards these patients. In very young patients, of course, there is an eye examination to be taken often. We have patients that are partially prepared and parents who are partially prepared. Eye doctors are excellent in preparing them, but they do not provide detailed explanations. And parents ask us for further information, for more detailed explanations. And so it is quite complex to explain certain things. The relationship to a young patient who becomes nearsighted is simpler because it has to do with our standard practice. Consequently, it is a softer approach. Why eye doctors don't have time to explain? Let's say so. I'm very open and frank. So this is an alibi. It is true that sometimes you are in a rush, but the time you use to communicate can be used better, can be invested better. It is also a problem of culture, of habits that you have developed. So when the consensus law was put in place, there is a paragraph referring to communication in terms of time devoted to care. So I think this is one of the key features, especially in pediatric age. So there is another word that is key: care. Yes, fortunately, there are the RTEP tests who are very helpful. I work with some of them, and I have an advantage that is sometimes I delegate. Whenever you have to deal with an eye doctor, you have acquired the right for an eye doctor to devote time to an explanation. For instance, an optician has a different approach because in their activity, not only they have to sell, but they adopt a special attitude toward customers. So it becomes less and less possible for us. Why? Because as you have heard, there are the waiting lists, and mean that in 2 hours you have to treat 4 patients. So there are plenty of activities to take into account, and this means that of course communication is key. If you listen to the voice of a pediatrician, well, my mother, for instance, felt better when she saw the pediatrician. Just by seeing him, she felt better. Now you have to devote time to explain very complex diseases. So I think we have to redesign the activity of the eye doctor, and we also have to devote enough time to important communications. This is what I do in my practice. I have a huge screen. I show the images on the screen. I sit, and my standard practice is, Nicola, I need you for 4 minutes to listen to me and let me talk. 90% of my examinations are recorded on my patients' mobile cells. So they can listen to what I'm saying, and I try to be as clear as possible because the recorded message will be listened to. When you hear about ERs where doctors sometimes are beaten up. This depends on the lack of education, but also a small percentage depends on we as doctors not to be so patient with our customers. So if we had the body cams recording how we act, our behavior, I think it would be very helpful for all of us to avoid possible mistakes. So the 4 minutes we devote, those 4 minutes, they are very, very few, but very precious. I have been talking for just a few minutes, but I'm saying a lot of useful things. So we have to optimize the time available, part of the time we have during the examination to clarify those aspects. I don't think we have to go too much into details, but we have to get trained in that. This is important, especially when we deal with kids. So being clear and getting to the point is key. The more information you get, the more confused sometimes people are. So you have to give the most needed information. You have 4 minutes to provide the correct info. When I talk to a mother while the kid is crying, I think I would avoid talking because she would pay attention to the kid and not to what I'm saying. Prati, would you like to... no, we have Andrea here with us. Andrea is one of my friends, and I think he could have a say. Do you go... are you happy when you go to your pediatrician? The mic, please. If you go to a pediatrician, are you happy? But your pediatrician gives you gifts or just examines you? If I only go there for gifts, I won't go there. You have to make sure that your pediatrician has not gifted your mom. Do you like your pediatrician? What does he tell you? Oh, it's a female doctor. My pediatrician is the chairman of the Pediatrician Association, used to give me candies. What about you? No, I don't get any candy. So, Andrea, you are right. They are the future. So, in my clinical practice, I have seen that when kids are examined, we also have to consider who is with them. When I have a mother or a father, it is very easy to communicate. If the granny is there, it's very difficult. It's much more complex because she doesn't hear what the mother is saying and what the doctor is saying. So generally, I don't want any granny in my practice. So when parents come to our practice, we generally talk with the kid first. We say hello to the kid. So 4 minutes, I think, are very effective to say what you need to say. But of course, it depends on the disease the kid is suffering from. If parents remain silent for 4 minutes, is great. Now with diagnostic through images, well, these images are extremely useful because if you see an image, you understand, you see right away what I'm talking about. The problem depends also on where you are, in ER room or in a hospital. So because of the time that is getting less and less shorter, you don't have to devote, you cannot devote much time to communication. In hospitals, unfortunately, people do not belong to eye structures, but they can be considered as nurses. And I think orthoptists would be extremely helpful, in hospital. Sometimes 4 orthotists and 1 eye doctor make more examinations than 4 doctors. So the presence of optometrists would be crucial. Yes, I wanted to share with you a couple of info. Our profession, we have in our profession a federation encompassing 18 different professions. So this federation has a code of conduct, a code of behavior, and there is also an article referring to the time of examination and the time of care. So we know that our healthcare system has changed drastically since 1978. Those who work in the healthcare industry know what I'm talking about. A patient cannot be studied and examined adequately enough to be refer or to give all the information needed to the specialist. So sometimes we collect info for the healthcare unit to provide the service, but we are patient centered. What happens in the oculistic world is that a waste of time is the refraction examination. So to have 30 different eye examination with full tests is almost impossible now. Paolo, would you like to add anything? The first examinations are the target of the general manager, and it is very hard to do everything. As far as the relationship between the eye doctor, the optician, and the optometrist, if there is a progression in nearsightedness, it is important to understand why there is such a worsening. There is a corneal curvature that has an impact on the worsening of nearsightedness and sometimes lead to keratoconus. If we act early, of course, we can maintain a good visual quality. This is why it is important to work in a team. Well, except for the noise, what about the cooperation among the different players? Well, I think that we need to know something more. We have biometries. We have the possibility to assess the characteristics of the cornea. It's not up to us to make a diagnosis, but to understand certain things is much simpler now than in the past. I think that we can build a shared cooperation pathway that is beneficial to all, primarily to our patients. So if I have to look on both sides, we have to find a way to structure our cooperation. And I want to stress what I said before. 4 minutes are crucial, are very useful, are enough, but very often, I don't know if it's the same for my colleagues, I receive customers who give me their clinical records and want me to explain everything. It is very embarrassing. It is not up to me. One last thing, and I give the floor to the audience.
So have we somehow blocked the epidemics of myopia? Have we managed to reduce this epidemic in the last couple of years? Well, I don't know, because when you have a growing trend, you don't know. But, my first approach is the defocus pair of spectacles to children who need spectacles. Well, clearly, if you have 0.50 at 5 years, you should not correct it. But this is my first approach for a very simple reason. Parents do not like drugs. Even if there were a drug, parents were not would not be so willing to give drugs to their children. So, by the way, there's a new drug, lysine oxidase, with a special function. It avoids collagen fibers to slide on the sphere, and in drops it seems as if it slows down the elongation defect. It is a world that is progressing at 360 degrees. There is not just one single optical mechanism, but my group was the first Western group to publish a report showing that the association between an atropine drug and the defocus lens provides the best results. And for us, this is a very important element that will probably further foster the relationship between doctors and opticians. As Fragoli said, I also have such an experience. So, of course, we have pros and cons on both sides. But most importantly, we are here to say that opticians are now finally very close to ophthalmologists, and we as ophthalmologists are doing our own part. And we are successful, because if you ask for a prescription of a defocus lens, we are the second in Europe to offer that, and I think this will allow a lot of people to benefit. Together with Fabiano, we've worked a lot on podcasts. Podcasts attract young people a lot. And we are organizing a podcast on communication, and most especially a podcast on the virtuous relationship between opticians and eye doctors. We will produce these podcasts soon. Nando supported me throughout this process. And again, so if you want to spend 20-25 minutes to listen to the eye doctor's or the optician's voice, I think this will be helpful. So, Nando, please support me also in the future. There's a question. Good afternoon. Well, I see that what we started 15 years ago in a restricted region, Puglia, is now being widespread. So you are saying that that, well, this was not available 30 years ago. I was really criticized during the conferences. Well, I didn't have the pleasure of listening to you during those conferences. In southern Italy, in Puglia, when I started in my role as a president, we started collaborating with the University of Bari and Foggia. And the eye clinic of the university is still there. We are celebrating the 15th conference this year. And this year we have a session dedicated to pediatricians because they are also interested in this topic. And I'm very happy to hear what you said because this shows that from a preventative viewpoint, we were long-sighted. And although we were not believed. But what is your question? Yes, my question is the following. We need increasing cooperation between the two categories. But first and foremost, we need training and education. We have been urging training and education in universities. So if you're able to overcome bureaucracy that so far has hampered optometrists to reach a higher education level, well, we would be more than happy to reach the same level of education as our American colleagues, because this would allow us to make a step forward in using communication and in doing something beneficial for patients. Well, that's clear. Tomorrow you will hear from me exactly this. You need better training, and this training has to be provided by the departments of medicine at universities. Well, this is my personal opinion, and maybe my colleagues disagree, but I hope we all agree on the fact that we need one single path for optometrists and orthoptists with two different results. But optometrists have to be trained with patients and not with fake eyes and simulations. Unfortunately, this is possible only at medical faculties, medical departments. I would be the first to teach if we had this possibility. Well, optometrists should be trained in eye clinics, and I fully agree with that. And I will tell you more. I would love to have community houses in Tuscany, in Emilia-Romagna. They already have community houses because we cannot rely on hospitals fully, as you heard from Marco. Hence, we need another form of healthcare provision provided by optometrists as well. If my office at the hospital is full of patients coming, well, you know, this is a shame. But, well, I talked about this with Guido Bertolaso, but, well, it's impossible to accept that for prevention you need to go to the opticians. I don't agree with that, and eye doctors don't agree too. And for this reason, there is a conflict. I don't know who suggested to overcome the problem of the waiting lists, going to an optician's, to stores for prevention reasons. No, we need training and education for these people too. I would be more than happy to teach. In my office, I have two orthoptists who graduated in optics and optometry and who followed then training in optometry with me, and they are happy with that. But, you know, this is my humble experience. I will talk with colleagues about this. Romolo is one of the few who supports this idea. We need a single training for orthoptists dealing with rehabilitation and the optometrists who will then deal with refraction. Anyone who would like to add anything else? Well, as you mentioned my job, let me add a couple of remarks. Our job was considered for years as a profession that idealized certain situations. Well, our profession has contributed the most to a dialogue that has led to the transformation of the healthcare sector since 1994. A lot of mistakes have been made. It's clear there are too many professional profiles, so we need to streamline them. We need to draft a dictionary of competencies and skills, so we need to reduce the number of skills without introducing new profiles. The Healthcare Commission is often asked to express their opinion about new career paths and new professions. But this is not a human or patient-centered approach. The person must be considered as an element to protect according to the Italian constitution. The final remark, yes, very quickly. I have to point out that orthoptists started in the 50s and optometrists started in and opticians started in 1928. Opticians are those who, throughout the centuries, have managed the correction and visual defects, sometimes even against the opinion of doctors. If you look up in the books of the end of the 19th century, you see that doctors not want people to wear spectacles. Optometrists are basically opticians, but with an additional training. And this is what happened in America between the end of the 19th and the beginning of the 20th century. There's just one difference. In America, lawsuits were won and new laws were introduced. We can win lawsuits, but no laws are being passed by the Italian government. Thank you very much. Our time is over, and thank you for participating in this roundtable.